Okay. Well, I will introduce myself. First of all, I am Julio Iglesias. I'm working the Santiago de Compostela hospital in Spain. My main focus on endoscopy, I only do AUS full-time. In the hospital we perform about 2,000 procedures of AUS every year and around 500 to 600 FNAs or tissue acquisition techniques that we can discuss while we're working together. I've been working with these models for the last years in this center and also in another learning centers. And I think this is going to be very practical. So I'm just going to perform probably the first approach and the first FNA, but the idea is that we can all do the procedures. Okay, so I will just try to guide you and help you in whatever I can help you. We will work with Sonia, this is our nurse, that is a key part of the FNA. Okay, and I will show you how we work together with the nurse, mainly because we do not do deep sedation, we do not use propofol, we use midazolam and fentanyl. For me, the nurse has a key part to stabilize the scope while you're doing the FNA, and sometimes the procedure can be done or not according to the expertise of your nurse, and so it's equally important. Okay, so I will just show you how we work together, because this is a team. In all endoscopy, I think the nurse has a crucial part, and also in AUS. What's your skill in AUS? Are you already doing AUS? Never?
Beginner.
Just really beginner, so we will go for the... Okay. So first we will take the scope. Okay. So we will use the 38. This is a therapeutic scope. You know that PENTAX has two different scopes, the therapeutic one and the slim one. You can perform all kind of FNAs with both scopes except the new 320 from Cook that is only goes through the biggest working channel of the 38. So it's okay because we are going to work with the 38. Okay? And let's begin. Hombre. Okay. Well, this is how I'm intubating with the left. I'm not left-handed. I'm not left-handed, but I always intubate with this hand. Okay, I will explain you why. Well, he's one of my trainees, so he also already knows that I intubate with the left hand. I mean, and this is another part of the very important part of AUS is that you need to have the patient very comfortable. So to have it very comfortable, you need to have him comfortable from the very beginning. So the reason of intubating with the left hand is for the position of the scope. So I always want to see in the mouth where I'm going. So to intubate with the light to the pallidar, you need to have the scope very torqued if you use the right hand. Okay? But if you use the left hand, the position of the scope is more neutral, so it's more comfortable for the patient while you're going through the throat, accessing to the esophagus. So that is because we do not have a frontal image, but we have an oblique image. So I always want to see where I'm going. So first I want to see the epiglottis, and then after I see the epiglottis, I want to check where the cilium mouth is, and then just by depressing the scope, just make a slight movement inside. Okay? That's just a trick that I've learned from my boss while doing... Okay. So let's go. But another part of the technique that is very important for FNA, as you see, I'm not really torquing the scope at all. What I'm just doing is just moving the complete scope. Okay, and that's also another reason for FNA. One of the problems of FNA is when you see the lesion, you need to have the scope as much stable as possible, not to lose the position. And if you make too much torquing, you need your right hand to use the needle. Yeah. So if I want to, for instance, if we want to go for, let's try to find some of the lesions that might be... Okay. I think the best way to start with the technique of FNA is with the diagnostic approach. Okay, you can be very good in the technical approach to anything, but first you need to know and to find what you need to puncture. If you do not find it,
you will not do anything.
You do anything. Okay, so we found what we want to access. Okay, so it's very important for the needle to go out to be really stable. So I can have this lesion with this position, but if I want to torque, I can also get it. But if I left my right hand from the scope, I need it to be as fixed as possible so I can always reach the lesion. Okay? And again, the needle will go out of the scope as softer as you have the scope in the straight position. Okay? And that is very important when you're trying to access a lesion from D2 or D3. You need to try to have the scope very straight to make the puncture easier. Okay, next step. Okay, I've already found what I want to puncture. So it's always try to put the lesion in the middle of the screen. However, it doesn't really care so much because we are going to see the needle and we are going to be able to direct the needle with the elevator. But the first point is to fix the tip of the scope. So now we just can almost put the hand out and we have always the lesion stable in the same position. Okay? So, and this is a very quiet patient with a very good propofol sedation, so it's going to be very easy. But if the patient is not sedated, the role of the nurse is key. Because for me to start to take the needle, I'm going to need 4 times to keep my hands out of the scope. And the key point to keep the scope in position is the nurse, that will hold the patient and will hold the scope. And will hold the scope from the very beginning and to give me a strength enough to be able to put the needle inside of the lesion. Okay? So we will go. We'll start with which one do you want to use? Small one. We can use the Echo 25 Procore. Procore needles and cytological needles, they're almost exactly the same in terms of use. There was some different when we use the Tracat needle, but we are not using it anymore. But for the use of this kind of needle, I mean, the system is almost the same. There's only one small difference at the beginning of the puncture that I will show you the difference between each other. Okay, the first thing that we can discuss a lot of things about the technique, suction or suction, style it, not style it. Honestly, it doesn't matter. If you have a good pathologist, all the parts of the technique are equally the same. For the Procore, it's very important to have. Oh, thank you. This is the 25 Procore. So, can you all see me? Okay. Before starting to do an FNA, we need to fix the needle. So first, we need to put the needle at the 0 centimeters position. Okay? What is the meaning of putting it at 0? That I will decide the amount of sheet I want out of the scope. It comes preloaded, standardized at 2 centimeters because it is the size of the case of both companies. Both companies, both Boston and both Cook, put it at 2 centimeters. But that's just because of the arrangement to put the needle inside of the case. Okay, so we put it 0. Stylet. There's 2 differences between the stylet. For the Procore, you need to have the stylet all the way down. Why? Because in the Procore, you have a side hole. Okay? This is quite small. We have this side hole. So the stylet is going to provide us with the strength enough for the needle not to bend while you're doing the puncture. Okay? So that's why when you're using Procore, you need to place always the stylet inside. For the FNA with the cytological needles, it doesn't matter because the needle, okay, there is no side hole, so there is no complaint. So in that case, you need to put it up a little bit because the stylet always goes deeper than the needle. So it's better to puncture with the needle, not with the stylet. Okay? So that's very important. And then there's another point. Once you make the puncture with this a little bit up, you push it in to clean the tip of the needle with the stomach wall or duodenum or esophageal cells. Okay? So this is important to prepare the needle to do the puncture. So once we have the needle prepared, and she has already performed the suction, because I always use suction. We can explain about suction and the um, a slow pull technique. We can discuss about that. Okay, so you see that if we have a very straight position, it's very difficult to lose the position of the lesion, and then we need to go. Well, this is it's like all of this.
Now if the scope is bent, I can also introduce the needle?
As much bended it is, as much complex is for the needle to go out. And to make something unsafe.
So better get it out and put the needle and then?
No. If you have a good position,
okay,
like this,
no need.
the first you need to go inside. Okay? And only if you have like this any difficulties, you can just try to adjust to make the needle to go in, and then try to relocate. But believe me, it's not such a complexity. Okay, now it's time to start. Okay, so time to start. We have a target lesion. Okay, so the first thing is to see the amount of sheet we want out of the scope. So we release the first wheel, okay, and we put this out. And you see by the AUS image that this is coming. Okay, I will use the elevator to see how it's coming. Okay, so we should do it. There is no vessels in the models, but it's a good idea always to use Doppler, not to puncture any kind of vessel. Now the sheet needs to be at least 1 finger out of the line. So that means that you are not going to break the scope. Okay? Because the only problem is that if you take the sheet, if you try to place the needle out of the sheet with the sheet too much inside, you can make a mess. Okay? So you just need to put the sheet out, so it's for sure there is no connection between the needle and the scope. Okay? And now we need to direct the puncture with the elevator. So if we want to go to this lesion down here, we need to direct to be here. So next step, always aspirating, because we need to have as less air as possible. And the next step is to release this part of the needle. This is a point here. You can ask me, what is this for? I mean, I've never used it, but what you can do is I just freeze the image and measure. Okay, if my needle is here, the distance from my needle to the lesion is 2.4. So I will never just try to get a safe space, so I will place the system here. So that means that I will never go with the needle deeper than 2.5 centimeters. Honestly, this is useless, because this is completely
visual directed.
Exactly. So there is no moment like in a percutaneous biopsy that you do not really see in some time. In this moment, you are always going to see the needle. And if you do not see the needle, stop. Come back and redirect again. Exactly. Because although it seems that you can only go for one direction, there is like 1 centimeter differences at the very beginning. That means that if you go 1 centimeter to 1 centimeter, there is like 2-3 centimeters that can be a difference from what you see. This is a 2D image, but we need to have enough in our head a 3D image. Okay? So I do not never use it because I want to have the capability of feeling it free. So then I start, and you see the sheet, and now you're going to see the needle. You see the needle? Yeah. Okay, so now I'm trying to go directly. Okay?
You can change inside the...
You can go and change until I go inside. Okay? Okay?
Here, where is the tip?
Here. This is an artifact, because if you have any doubt, just if you put it, you see, the cook needle has a very wide tip in the very tip. So you can easily see where you have the tip of the needle. Okay? So here we are inside. Now we can remove the stylet. Okay? and that is the easiest. We release. I used to wait. One,
comes with the
two.
needle?
Sorry? Yes,
Needles
yes,
comes
yes,
with
yes,
the
yes.
Procure.
Yeah. And with Procore, with cytological needles, with Boston, and all of the companies with needles bring the syringe. And now it's to and fro movements. You need to go. And this is different tricks, okay? I like to do the fanning technique. The fanning technique is I direct with the wheels to try to cover every part of the lesion, okay?
Multiple passes.
Exactly. So I
How many
want
passes to overcome the pathology?
exactly. This depends on whether you have the pathologist or not. So I'm here doing the FNA, you see, going in and out. Those are the so-called to and fro movements, okay? So you can manage to do 10 to 15 to and fro movements, but each time you remove the needle and you put it in again, that's a pass. So it's not the same the number of passes you do with the first puncture than the to and fro. And it's also been measured how many to and fro movements, and the minimum, the study said that there need to be at least 10 to and fro inside of the lesions. And it's better, of course, if you perform it, changing the positions. So what you try to get is as much, okay? So this is a standard procedure. Sometimes we can just say, okay, this is okay for me. So I just stop suction. And now there is a theory. This is not the best needle, but this is a model, so we can discuss. Don't do this with the Procore, okay? But there are some guys that say, okay, since it's very complex to remove all the system again, instead of removing everything, flushing all of the material inside of whatever we can discuss where to put it, Anand Sahai says, okay, I'm going to do a second pass, but without moving the needle. So I just retrieve it and let me do it again. So I will try to. So this is like an additional pass, okay, that we can perform. And this is the theory from Anand Sahai. This is how he you know that Anand works in Montreal and is one of the most skilled guys in the US. So now I'm going in again, okay? Go in and in, I get into the lesion, and for him, this is an additional pass. Okay, so he will just open and do the punctures again. You see, we are inside of the lesion again. So this will be a second pass, okay? So the advantage of this is that the study said that the use of the stylet, it doesn't care. You are not going to increase your accuracy by using or not the stylet, but you will reduce the time of doing the procedure while doing the passes without taking the needle out, okay? Well, this is, we will just stop. Please, always close this and remove. And that's an FNA. It's not so. Once you identify the lesion, it's easy. Okay? So, your turn. And we're going to go to make it easier with the, because it's for the technique is, I mean, the best technique, the best lesion to start are cystic lesions. Because they're very big, softer, and it's very easy to see the tip of the needle. So since we have a very nice cystic area.
With well-demarcated margin.
Sorry?
Well-demarcated margin.
Yes, but it's very nice because you are going to see the difference, and it's better for you to get image to the to how to put the needle inside. So, whose turn is? Whose turn? Come on.
Go out and go again?
Sorry?
Go out and go again? Or
Yeah, go ahead. I mean, we have everything there, so
straighten the scope.
just straight the scope, and now go again, try to find the lesion. Don't put it out so much because not to break the esophagus of the model, so we can last it longer. So you can go under endoscopic image, you can go. Remember that you see not in the front, but it's an oblique B. So you are not going where you see. So for instance, if you want to go inside, exactly, you need to lose and like going in that direction.
Slide.
Exactly, go ahead.
There is resistance.
So just lift the tip a little bit. Okay, that's it. Go on. Perfect. Go on. To try to place it. Okay, go ahead. So now, okay. Now this is like endoscopy. I mean, this is not an endoscopy, and this is. I always say that EUS is like dancing.
Yeah.
Okay, EUS is like dancing. So it's like dancing. So it's like the tango. Okay, not like salsa, but like the tango. So you need to go like this and like this. If you do this tango movement, I'm from Spain, so we're close relation with Argentina, okay? If you make the tango move, it's very easy because you're going to have much more stable deposition and you're going to find everything easier. You see it. You got it. And this is an endoscopy, an ERCP position. For EUS, here, and the scope needs to go here. Because the idea, I mean, it's very simple. This is the tip of the scope, okay? My finger is, and this is the tip of the scope. And this is technique of EUS. But again, you need to have an idea of the technique on EUS, because if you have the technique, you will be able to find the lesion. If not, so what do we need to do? This is not like an upper GI, that you want the scope to do something like this, to go to the retro. No. You are not going for the stomach. You are going for the surrounding structures of the stomach. So you need the scope to do this. Okay? So turn. If you do it like this, you will do something like this and something like this. No. You need to have it like this position. So that's going to make you much more easier. And this is even more clear in patients. Dr. Martinez Alcala, am I correct or not?
So we don't do the close position?
No, never. I go always from this position to this position. And with this management, you are always going to have the scope straight. So this is the endoscopic approach. To have the scope, this is all endoscopists of upper GI and very advanced, because for endoscopy you need to have the scope very straight. And I learned this from so Jack's doing that for some specific moments you need to have the scope. But for EUS it's just another option. It's just to be more comfortable. And it's tarang. I mean, for cystic lesions you need to use the cytological needle. For solid lesion depends on what you expect from the FNA. Do you want histology? Go for the Procore. You just need cytology. It does. I always go for Procore and as big as possible.
Only two situations, lymphoma and the autoimmune.
Honestly, depends on your oncologists. For instance, we use for lung cancer histology, because they want to know the ERCP test, they want to know the TF1 mutation, they want to have a lot of information on immunostaining, because it's the directed oncology. So we always need to have the elevator down, so it's going to be easier for the sheet to go out, and then we just need to push and secure. So now it's your turn. This is a cytological needle, so the first thing is to remove a little bit the stylet. Do it, a little bit. And it's in the Boston needles, it's easy because you just until the white part. That's okay. Okay. Now, okay, keep it there. No, it's okay, it's perfect. So, see, she's holding the scope for you, so you are never going to lose the position, ever. That's why this is a combined procedure, because you need to have your hands, you will need to have 4 hands, but that's why it's a combined procedure. She's going to hold the scope for you, and that's going to make your life much easier, okay? So now you release this first wheel.
Left side or the side? Left side?
No, this is like other side. Okay, now, so just to try to bring it down until you see it coming out of the, okay? Perfect. No. One finger, remember, the row, one finger. And when you have one finger, you stop and lock it. And then you release this part of the, No, this is very good. Okay. And now is the time for the elevator. Use the elevator up and down, and you see how the needle always aspirating. This is just the opposite as endoscopy. In endoscopy, you're always insufflating. Here, you're always aspirating. Okay? So you always aspirate continuously. And now, use the elevator to use no with this finger. This hand is for the needle. You need to manage everything. Okay, try to find the okay. No. But if it goes, look at me. If it goes this way, you need to use the elevator to put it down. So, and now, see. No, but yeah, and aspirating. The problem is, if you no aspirate, you are going to have air.
Aspirate and put a little bit up.
Yes. Go. Yeah, that's all. Finito. Easy. Now, you just put it down to release, and then, what are the to and fro? The idea is not to use the hand in this position. Do you see how the handle is built? And this is exactly the same to this. This is built, so this is the position. So you use it like this. And this is exactly the same. You hold it with a complete hand and you move it like... Exactly.
Finish?
Easy. So once you finish, okay, in this case what we should do is just, we remove the stylet, we place the syringe, open, and to and fro. And this is, and you always need to look at the needle. I mean, the way of not using it is because you can see it all of the time. So this is a complete directed procedure. That is one of the good things of this system, of this FNA as compared to percutaneous FNA, that you sometimes can lose the position. Thank you. No. Now, when we finish, first, stop suction. Second step, remove the stylet, the needle. No. This part, up. Up, okay. Now, we put this up. And second, finito. And instead of moving so much, this hand is just, if you use this hand, like this, it's even better. Okay, so the idea is just to move. If you move it completely, it's easy. The most difficult part of EUS is imaging, not the technical part. Is
diagnosing lesions?
Yes. If you do not diagnose the lesion, you will never be able to biopsy it.
Yeah.
So the most important part is to learn to do an EUS, and then you can learn to do an FNA. And if you go, we can have a lesion here. Aspirate all the time. And EUS. Your usual position for endoscopy when you're doing an upper GI and a colonoscopy is to have your finger insufflating air and never aspirating. EUS. Never insufflate, always aspirate. So you need to change your fingers to a different position. Because if not, you are going to have a lot of air, and all of those white lines is air. So that's what you didn't see. So you just need to be aspirating. If you find sometimes that the image is not changing, it's because you may just have some stomach part inside of the lumen. So it's like cuando chupas. Okay, so you need to just release suction for a moment, and then it's just moving the scope everywhere. There's another trick for EUS, and this is just tricks for EUS, is that you need to have the distance between your hand and the mouth is like a quarter, because that gives you the space to go to and fro with the scope and really to be able to manage the scope properly. If you are too close with your hand to the mouth of the patient, it's going to make your life more complex. If this is the pylorus, just as an example, and I want to go to the pylorus, I cannot go this way, because if I'm doing this, what I'm doing is going against the stomach wall. So you need to look at the incisura angularis. So if you look at the incisura angularis, the scope will really go this way. Okay, because the light is like this. ERCP is like this, AUS is like this, and normal endoscopy is to the front. But this is very important because you may have some problems just in imaging and just in orientation. The many few moments that you need endoscopy just because you are not looking to the front. You are looking a little bit up. Okay, and that's the difference from ARCP, that you are really looking up completely. Okay, okay, yeah. Let's go here. So this is what we want to target now. Yes, I will see if I'm going to let him next week do the procedures, the FNAs or not in my patients. Just think that this is a cystic lesion with a solid part. So always your target is not the cystic part, but the solid part. Always, because that is the more suspicion to be a malignant part. So okay, go ahead. That's all. Okay. So at the end, always, the most important part of an AUS is not doing the technique of the FNA. Because at the end, the FNA is place the needle, fix the needle, shear a little bit out, release the wheel, make the puncture, put the syringe, remove the needle after stopping the suction and release take everything out, and then manage with the sample. So at the end, it's not such a complex procedure by itself. It's just that you need to learn the steps. But again, the most complex part is to try to be able to find what you need to biopsy. Take the same needle if I first puncture the lymph node and then I go to the lesion. But I will never go first to the lesion and then to the lymph node. Because if the lymph node is negative, you can make it positive. But in the opposite, if it's negative the FNA of the lymph node and you go to the head of the pancreatic mass, it doesn't matter. Yes. It's better to use 2 needles, always better, for each specific site. Mainly if it's going to make the change in the treatment of the patient. If you go for a pancreatic mass and you have a liver lesion, it's better to go for the liver lesion because that you are going to confirm an M1 lesion. Okay, but sometimes you need to go for, and the other day we perform a case in a liver mass with lymph nodes and with a pancreatic mass, but with a patient with a history of a colon cancer. So we target liver and we also target the lesion. We didn't went for the nodes because we didn't really care. The important point is this a primary pancreatic lesion? Is this a metastatic pancreatic lesion, or is a primary pancreatic lesion with metastatic liver lesions from the old colon cancer? So since it was a very complex decision, we need to target everything, and we did it everything by a US.
And used more than 1 needle.
And yes, we used 3 needles. So well, better my boss not to know that I used 3 needles in that case because he can kill me. But at the end, it's very important for the decision of the patient. I mean, it is completely different. If it's a primary pancreatic cancer with pancreatic mets, that's completely different because the treatment is completely different.
I can use the needle twice in another patient.
Never, ever, never. I mean, this is just
They do something
one
like
use.
in India.
Yes, but I've discussed. I was in India this summer in a meeting in Delhi, and I have that question. And I think that's if that happens, there is a need from the companies to decrease the cost of the needles in those countries because it's not acceptable to use the same needle in 2 patients. It's not acceptable. I mean, of course, if you have if there is no option, and there is, or I use same needle in the same patient, or I will not be able to perform the procedure. Okay, I will need to sit down and pros, contras, and decide if that is really the point or not. But I mean, in the first world, and it seems that we live in the first world, we should never, ever use the same needle in another patient, ever. This is, I mean, we are moving, the move of endoscopy in all materials for endoscopy is all single use. And in the past, sometimes we use for ERCP the Los sphincterotomes. The sphincterotomes we just sterilize and using in a couple of patients. I think today that is not acceptable, and we used to have one single-use systems for every patient. I mean, at the end, the companies are reducing the cost of this material, so it's possible. It's not a nightmare for the hospitals to buy those systems for all of the patients. Okay?
Submucosal masses.
Tell me.
Outside the course.
Hey, tell me.
What's your strategy?
Discuss with the surgeon, always. Never do nothing without the knowledge of the surgeon. Whenever I take FNA, I will always go for a Procore. Always. The bigger, the better. Or if not, sometimes I'm using now the 19 Flex. The 19 Flex of Boston. But preferable, the Procore. However, we are targeting less and less subepithelial lesions. Because the surgeons, what they really want us is just to place some ink, tinta china, to mark the lesion and leave it. They will remove it.
Mark what?
The lesion in the stomach. I do not know the ¿cómo se dice tinta china?
So it appears from outside?
No, that you can see. ¿Cómo se dice tinta china? Jorge, ¿cómo se dice tinta china en inglés? Tinta china para marcar una lesión. Ink. We placed ink inside of the lesion.
Yeah, so that the lesion appears from the mesentery when the surgeon comes?
No, that's for laparoscopic approach.
Yeah.
Because they're going to remove in a laparoscopic approach, but they need to see the lesion.
Yeah.
So,
See, as a lesion, you inject ink?
yes, but with the normal systems for the bleedings, I mean the normal catheter.
Yeah.
By the side, I used to do it by EUS because it's very simple. I'm with the scope inside, so I just place a little bit of ink and leave it for the surgeon to be removed by laparoscopic surgery approach. That is our approach. Submucosal, yeah. I mean, when we're speaking about big 3, 4, 5, yes. Because if it is not, and there is not appearance of a gist, do nothing. Leave it. Leave the patient home. Never see him again because there is no need to. There is no need to. No.
Metastatic or lymphoma?
But you need to have the idea that is the suspicion. I mean, if it wasn't just an isolated finding, casual finding, patient comes from an upper GI, you see something that seems to be a subepithelial lesion, you make an AUS. I hate that AUSs because they're terrible. They use for the subepithelial lesions, not the big ones, but for the small ones. But always, if you find the lesion below 2 centimeters, very good looking, forget it. If you want, just make an additional AUS in 1 year's time to see if it really increases in size or not. But if not, don't do anything. The risk of malignancy or evolving or whatever in a small subepithelial lesion is close to zero. Other thing is that when you have a patient with a history of a renal cancer, the history of a colon cancer, the history of a lymphoma, and then in the follow-up you find that lesion. Okay, that's different, complete workout. In that case, you need to rule out the presence of a metastatic disease.
So what do you do for these lesions? The Procore?
I mean, depends. I saw the lesion. I do nothing at the very beginning. I speak to the doctor that sent me the patient, and I explain the findings, and I just make a workout. Okay, this is a previous lymphoma patient with this new finding. We will go for a thoracic and abdominal CT scan. Is any other additional lesion? We will make one strategy. Is the only lesion subepithelial mass? Then what is the size? It's below 2 centimeters, very good looking. Probably we make a straight follow-up. If it's from the second layer, homogeneous, with not contrast enhancement and with a normal elastography, follow up. Always.
Yeah.
Always.
Always, huh?
Always. So I will just leave it and follow up. Follow up. Okay, it's a green, soft lesion. Probability of a leiomyoma is very high. Do nothing. It's a very bad looking, 2.5 centimeters. Discuss with the surgeon.
Yeah.
Only lesion. So we met together, multidisciplinary approach. We met all of us together and make the decision. We want an FNA. I do an FNA. For that cases, I prefer to have the pathologist in the room because the rate of negative cases for subepithelial lesion is very high. So that's one of the few indications today. I want to have the pathologist with me while I'm doing the case. But the workout of subepithelial lesion is a nightmare, complete nightmare. because we start to have a lot of requests for 8 millimeter subepithelial lesion. A nightmare. I don't like those cases at all, but we need to do them. Okay.
Thank you very much.
Thank you.